can be natural or deliberate in terms of infection. So in terms of outbreak planning that I talked about, these are some of the things we need to do. It can be preparedness, rapid response team need to be put in place. And this rapid response team is better they are put at the subnational level. You don't only want to build capacity in a place like Abuja and leave all the states alone. You don't want to build at the state capital and leave the local governments alone. You want a robust system wherein if anything is happening in the local government, it can be triggered to the state and can be triggered to the national. You want to be able to respond within 24 hours or within 48 hours. That's what you should be aiming at. And so testing your capacity again and again and seeing what you can improve will help you to do this. As we mentioned, you can develop control and contingency plan. I will show some of them. You can develop simulation exercise. I was speaking with a team in Yobe just about a week ago, and some of these slides were borrowed from the discussion I had with them. You can also have rosters of experts before things happen. For example, if an outbreak happened in Yobe or in Maiduguri, who are the experts we can call to get out to the field to begin to act immediately? Who are the people closest to the source of infection, to the index case, that we can mobilize to begin to act immediately so that we reduce what we call critical response time. That's time to respond to an outbreak. The much you can reduce it, the better in terms of disease management. And so also during the outbreak period, these are some of the things you can do, and the post-outbreak period is also there. So in terms of some of the documents I talked of, these are some of the documents we assisted the Kenyan government to develop. Right on the right-hand corner there is the one for anthrax, which is prepared for 2021 to 2036. We have for brucellosis, there for rabies, for RVF, we have for avian influenza and others too. So these are some things that we need to have as government, and it should not only be kept in government offices, should be distributed to the private sector, distributed to the different local government, different states, so that everybody has it. You should have it electronically. For example, if you go online now and just type any of these documents, it will pop up on the Ministry of Health website in Kenya. And so you can download it as an official or as a citizen of that country or as anybody who want to refer to this document. So in terms of the challenge that we are dealing with here, the issue of anthrax is a big challenge, and it's a challenge that lives with us every day. It's a conundrum because it has the human component, the animal component, and the animal component is also wildlife and livestock, and has the environmental component. Briefly, let me give you the story. In Kenya, the Maasai actually call this anthrax, they call it early rain disease. Why? Because at the beginning of rains, it's occurred a lot. And why does it occur a lot during the beginning of the rains? You know, they have a lot of drought in East Africa. So during the wet period, they have grasses for the animal. During the dry period, these grasses are gone, and they have to move this animal as pastoralists from places to places. But you know, in the wildlife park, because those areas are protected, they still have some areas that have grasses. And so at the beginning of rain, the following year, you know, the wildlife, maybe the wild ruminant that died of anthrax the previous year, they are not buried because the wildlife rangers are more interested in preserving them from poaching, not interested in their health aspect mainly. So this animal that died, the wild ruminants that died and are buried in shallow grave or are not buried at all, they become the source of infection for livestock who came into the wildlife park to eat grasses, and they pick infection, bring it to the human community. Some of the livestock died, and the human being, the Maasai, typically we split those type of carcasses and distribute it in the community. So you begin to see human infection, animal infection, and then if you do trace back, you find out they possibly have a link with the wildlife. So in terms of that, it means that we have to think of dealing with the wildlife and rangers the officers that deal with that, dealing with the people that handle the animal health, that's livestock health, dealing with people that deal with environmental health, as well as people that deal with human health. If you leave out any of these, you seem to be doing a partial role, which will bring no complete resolution of what you want to deal with. So in terms of some of the anthrax cases, these are some of the cases we've seen. For example, this boy you see on the left-hand side, we were talking with the parent. The parent was even saying, no, it will go by itself. It's just a skin problem. It will bubble out and then it will dry and go off. And so in most cases, when situation starts like that, most people in the rural and peri-urban area, they really don't pay much attention to it. They leave it to chances and say, oh, it will go. And when it's not going, then they begin to treat with maybe tetracycline and home treatment or so. And only when it's getting critical and serious, that's when they begin to seek hospitalization. Like you see for the case of that girl on the right-hand side, that girl lost almost the 2 eyes in this situation. You see, these are more pictures we have from the field. These are some of the resolving one, but still you can see that it had really dealt with the boy's hand. We have more picture here. You can see like this Maasai girl that you see on the right-hand side had infection the previous year, and that was what affected her hair. And then had new set of infection the new year. You see the little boy in the left-hand side, you can see the infection in the hand. This is a serious case, but I tell you, in the peri-urban and rural area, they hardly pay attention to this until it's becoming more serious. These are more pictures that you can see. You can see both the domestic animal, you can see zebra, we've seen giraffe, we've seen gazelle, and different type of animal. So it can also mean a loss of significant population of animal you will want to preserve, like all these very high valued animal. You're losing them easily, and you are not getting any resolution. You can see it also affects production and productivity. Like this is a cow that typically is milked, and they get close to 10, 15 liters of milk from this cow. When it has this infection, it could not even produce a single liter of milk at this stage. So in terms of the observed sign and some of the things we've observed in human cases that we've observed around East Africa, we found in almost 100% of the cases, you will have fever. But lymphadenopathy, that's the swelling of the lymph nodes, in about 60 to 65%. Headache at the time when there is fever, or at the beginning of the case, you have some headache. You may have neck and head swelling also. And upper limb, that's hand, and the upper limb that are used to touch the skin and inflame in processing those animals that died of anthrax. You see this. Trunk may be affected. Abdominal swelling, you may see it in less than 20%. And you may also see difficulty in swallowing, especially at the beginning of the cases. What are the scientific and specific response we can do to respond and control anthrax? These are a list of things. For one, we need to put the instrument and tools that are necessary to assist us in place. One, some of those instruments and tools include our legal policy and institutional framework. For example, the setting in terms of reporting, is it adequate? Can the local government report almost immediately to the state and transmit the same to the national within a day? Do we have policy? For example, I come to a farm, your farm has anthrax, I want to control it and say you can't move your animal. Do I have a legal backing? Do I have a policy document that is institutionalized that said I can do that? If I don't have that, you as a vet or private farmer can say, no, you cannot stop me from moving my animal. On what basis? So we need to review this. These are the activity government need to do to see that it's there periodically. There need to be stakeholder mapping for anthrax prevention and control. Who are the people that are involved in this anthrax? Don't only think it's only the government vet officer and the public health officials and the environment officer. What of the livestock herders? What of the pastoralists? What of the markets people that deal in livestock? These are all people that we need to evaluate and see what are the capacity, what are the contributions they can make. We need to do the analysis of strengths and weaknesses in our system. For example, systemic weakness, systemic strength. What are the low-hanging fruit? For example, if the the pastoralists, if they have a large group, like you have some of the cattle herder association, like the MACBAN and all those things, can we talk to them? Can they be the first source of information in reporting anthrax? Once they see any sign in their head, they report immediately to the nearest vet office, and all those things can be opportunities. We need to develop a strategic framework that shows how we want to coordinate and do this. And for the strategic framework, these are the necessary things that it must include. It must have a sort of an overview of a situation analysis. What is the situation in the country? Where are the hotspots? Where are the low risk area? Where are the high risk area? We need to know what are the drivers of the disease in Nigeria. For example, if processing of things like mama is a risk, we need to work on that. If a cell of hide and skin is a risk factor, we need to know that. We need to define the human-animal environment conundrum. Where are the high-risk areas? For example, the wildlife to domestic animal conundrum may not be much in West Africa because we really don't have as much wildlife as they have in East and Southern Africa. So but we need to define that and know what we are dealing with. The pathogenesis and clinical manifestation. What are the pictures we see in the field? We need to put this together and get ready. In terms of diagnosis and challenges to effective diagnosis, we need to know. For example, we know that diagnosis in the rural and peri-urban area may be weak because most of our facilities for effective diagnosis are over-concentrated in the central area, maybe Abuja, maybe VOM, maybe Lagos. What of the other areas where we have the high-risk group? Do we make any provision for rapid diagnosis in those places? We need to begin to review this. Prevention and control, we need to take it seriously. And also socio-economic impact of anthrax. We need to define it. We need to undertake it and know it beforehand. For example, if you are invited to the National Assembly to come and speak about anthrax, you go there, you begin to talk of the pathogenesis and all those. You will make no meaning to most of those people sitting there. But if you tell them the economic value of the livestock, the economic value of the anthrax, how it impacts human, how it affects livelihood, how it will now affect the people who will vote for them in the next election. I'm telling you, you will get their attention and you will get response to whatever you come there for. So what are the things we also need to do? We need to delineate the country into high and low risk areas, I've said. Primarily prioritize the implementation and elimination in high risk zones. We also need to implement the prevention and control strategy. I've mentioned that before. It's not an odd document. It's something we need to make active and use from time to time. We need to target elimination in human. And also we need to do periodic baseline, midline, and endline monitoring. It's important for us when we are implementing activity to also monitor them periodically to see whether we are making progress or not. While I was preparing this, I saw this picture I just put there that the government sealed a pharmacy shop due to anthrax situation because the pharmacy shop, that's human pharmacy shop, is implementing illegal veterinary services against anthrax. You know this is wrong. So this brings us to the stakeholder. So who are the stakeholder and what area do we want to do stakeholding on? For example, area of coordination, policy, standard, and strategy is important. This picture is that of Kenya, but it's similar in most sub-Saharan African countries. Who are the people we need to involve in coordination, policy, standard, strategy? Is the government, basically, the Council of Governors, the relevant offices, and the relevant authority. We need to think of the technical support, capacity building, and resource mobilization like we are doing here now. These are some of the technical agencies we can involve, the strategic partner in the country, the international donor agencies, the different resources we have, your universities, the research institute, the enforcement of law and regulation. That's the Ministry of Interior, the police affairs, the military where necessary, and the local government authorities. The research and training. The research institution is needed here. The stakeholders are needed, the different government agencies and international partner dealing with research. Vaccine production, here VOM comes in. If we are talking of human vaccine, we should also think of who are the people who can do human vaccine. Biosafety and biosecurity, like Dr. Sati is a certified biosafety officer. You have quite a number of them around the country. From time to time, They need to talk together. For example, the MVMA meeting, the NMA meeting, the relevant meeting where these people can speak. You need to get their voice out there to let people know about what is being discussed. In terms of public awareness, this is where we need to partner with the media houses, the TV, the radio stations, advocacy and communication. You see, the farmer organization is important, the veterinary association, the animal health association, the human health association, and the relevant organizations that can fit into this, as well as the implementers of the strategy, which is the whole of society. Nobody can be excluded in this type of a thing. And for example, when you talk of some of these issues, for example, people in the lab that deal with anthrax, they need to have a lockup facility so that the anthrax they kept in their laboratory is not easily accessed to be taken to create bioterrorism somewhere else. So it's a whole of society approach, basically, and nobody can be left out. I would like to stop at this point, and thank you for giving me this platform to present. Thank you.
Thank you, Dr. Fashino, for that brilliant and very informative presentation. Thank you. Before I go further, kindly allow me, I have to briefly talk about Dr. Fashino's brief CV, briefly, so that our participants can know who is Dr. Fashino. Dr. Folorunsho Fashino is a Nigerian veterinarian who has spent a significant part of his work life in parts of Africa. He is well traveled within and outside Africa. He currently works at the Emergency Center for Transboundary Animal Disease, ECTAD, as country team leader in Kenya and Tanzania. He used to be a professor at the University of Pretoria, South Africa. Currently, he works as a One Health intelligence and early warning expert with FAO in Rome, Italy. Dr. Fashino holds a Doctor of Veterinary Medicine, 2 PhDs in molecular and classical epidemiology from University of Pretoria, University of Utrecht in Netherlands, focusing respectively on transboundary and zoonotic disease. His area of interest include infectious disease epidemiology, health economics, disease ecology, modeling, using One Health approach. Dr. Fashino has worked for over 20 years exploring zoonosis, antimicrobial resistance, epidemiology, basis of transboundary animal disease in Africa. He has published over 200 peer-reviewed papers. Fashino. Yeah, so your presentation, you're able to catch my attention severally. You are able to reel out a strategy for response and control of anthrax disease, even at the different stages of the outbreak. And again, you're able to reel out the responsibility of everybody that a concern. I mean, we are all concerned in the infectious outbreak, particularly this anthrax, at the government level, at the community level, and at individual. You're able to apportion responsibility for all. So I think we will take note of that. Thank you very much, Prof. Kindly be on standby for questioning from our participants. So I think Dr. Sati Umbulu presentation is slides are ready now. So Dr. Sati.
Yeah, thank you.
Yeah, so Dr. Sati, it seems your slide, your PowerPoint is loaded with pictures. So okay.
Okay, I've tried to share here.
Yes, yeah.
I don't know why. So I think it's everybody seeing the slide now?
Yeah, we can see it now.
Okay, so I'm sorry again for the glitch, the technical glitch. Once again, good afternoon all. So
Good
I'll quickly
afternoon.
run through the slides just by way of introduction. So as Dr. Fashner rightly has said, anthrax is a zoonotic disease that is caused by a spore-forming bacteria, Bacillus anthracis, that affects both animals and humans. And it has a huge devastating effect on the livestock sector. And not only the livestock sector, it also poses a threat to public health. And as has been mentioned also, it is a potential biological weapon because Bacillus anthracis is the most potent biological weapon because of its hardy spores, various modes of infection, and also because of its high mortality. The spores can survive in the environment for decades. So other names that they call anthrax are malignant edema, malignant pustule, wool-sorter's disease, carbon, splenic fever, and in Nigeria, especially the Fulanis, call it Cepha. Brief history of anthrax. Anthrax is as old as mankind. It is an ancient disease, and the name was derived from the Greek word anthracis, which means caul, because caul black skin lesions are usually found in cutaneous anthrax in humans. So the name was derived from that lesion that is usually seen on the skin of humans that are infected with anthrax. It was also reported that the fifth plague of Egypt, which occurred in 1491 BC, which killed cattle, sheep, goats, camels, horses, and donkeys in Egypt, were thought to be caused by anthrax. So the animals affected are as listed. It is mainly, or naturally a disease of ruminants, especially cattle, sheep, goats, but of course, horses, donkeys, camels, pigs, dogs, and wild animals, especially ruminants, are also affected. The transmission of this disease, especially in animals, is by ingestion of contaminated soil or pasture or water. It could also be through inhalation of dust contaminated with the anthrax spores. And also biting flies have been implicated as mechanical, transmission of this disease. And for humans, it's through inhalation of the spores. It could also be through contact by handling of infected animals. It can also be through ingestion of contaminated animal products. And recently, another dimension has been added to the transmission of anthrax in humans, which is referred to as injection. And this is usually seen in people that inject themselves with drugs, especially heroin. They have been found to also transmit anthrax through injection. And as you can see, the cycle, which Dr. Fashner also talked about, the anthrax cycle, usually, like we say, is a disease of animals. So when an animal dies of anthrax, the vegetative form of the anthrax is released into the soil or this environment. And when it is exposed to oxygen, the sporulate and form spores. And these spores can be ingested or inhaled by animals or by humans. and leading to infection in animals or humans. So some of the clinical presentation or signs, especially in animals, are sudden death of animals. So once there's sudden death of animals, anthrax is usually a suspect. And then bleeding, usually unclotted blood from natural orifices. As you can see in this animal, you can see blood oozing out from the nostrils. There may be diarrhea, which could be bloody. And then if the animal dies, especially within some hours, normally if an animal or a human being dies, there is usually what we refer to as rigor mortis, that is stiffness of the muscle. When an animal dies of from anthrax, there is this absence of rigor mortis, and sometimes blotting of the carcass. For pigs and carnivorous animals and also primates, usually the disease is manifested the chronic form or the subacute form, and usually it is manifested or shown by edema and swelling of the face and the neck. And then sometimes they may show some of the signs that are also shown in ruminants. And for humans, the disease is usually presented in three forms. The cutaneous form, which is the most common form, about 95% of cases is the cutaneous form. And just like Dr. Fashina earlier mentioned, the disease begins as a clump of small blisters or lumps that may itch and swell and eventually may develop into ulcer, and then form this black depressed center, which is very, very typical of anthrax. The pulmonary or inhalation anthrax is manifested by fever, cough, dyspnea, and fatigue. And the gastrointestinal form, that's the form that is gotten through ingestion of contaminated meat or contaminated food products, is manifested by fever, fatigue, headache, nausea, vomiting, abdominal pains, and diarrhea. And then the injection form that I earlier mentioned is usually manifested or shown just like the cutaneous form. And this particular form spreads very rapidly because it is injected. It can spread throughout the body. So who are at risk of this disease, anthrax? Usually it is people that handle animals, especially veterinarians, veterinary laboratory workers, farmers, abattoir workers, butchers, wildlife handlers, hunters, park rangers, processors, importers and exporters of animals or products like hides, skin, bones, and other animal health workers are at high risk. And people who also consume animals that may die of anthrax. Dr. Fashina mentioned that, when in the Maasai area in Kenya, when an animal dies, even in Nigeria, when animal dies, people will rush there and then begin to open the animals and then share the meat. So most times this is usually the route of infection, humans. Also healthcare workers, diagnostic laboratory workers, caregivers that are exposed to those that are infected are also at risk. Now, the occurrence and distribution of anthrax. Anthrax, as we all know, is a disease that is widely spread. It is almost everywhere in the world. You can see the map. This map is showing all the areas where we have anthrax. Some areas are endemic areas, some are areas where there have been epidemics, especially the red areas. And also there are a few countries that are free or said to be free or for a long time have not had outbreaks of anthrax, but generally it is a disease that affects animals and humans and is found almost everywhere. Now, the outbreaks, the global outbreaks, just to mention a few, in Zimbabwe in 1979 to 80, about 10,000 cutaneous anthrax cases with 182 fatalities were recorded. And in Russia in 1979 also, there's this popular and very popular incident where an anthrax outbreak occurred in then Soviet Union in a military hospital that killed 68 people out of 79 that were infected. And in Tibet in 1989, 507 anthrax cases resulted in 162 deaths. So in West Africa, there have been outbreaks of anthrax in many West African countries. In fact, West Africa is said to be, an anthrax belt. And that the recent outbreaks in the West African region testifies to that. Recently in Togo, Burkina Faso, Ghana, and Nigeria, there has been outbreak of anthrax. As you can see, these red areas are areas that are referred to as, epidemic areas. So in the West African region, you can see that a lot of countries, they have had outbreaks of anthrax. Now, in Ghana, from 2005 to 2016, a total of 38 human deaths from anthrax were reported in Ghana. And out of these, 30 of them was from the Upper East and 8 from the Northern region. In fact, the recent outbreak that occurred in Ghana was also from the Upper East region. And most cases occurred, like I said, in the Northern area. And most of the deaths occurred during March, April, and June. That also agrees with what Dr. Fashina, Professor Fashina mentioned, that, it usually occurs close to the rainy season, corresponding to seasonal peaks and also the concentration of livestock. In June this year, an outbreak again occurred in Ghana, and over 30 animals were reported dead, with 13 human cases and 1 death. Okay, this is also talking about the global outbreak. In China, 898 and 1,210 anthrax cases were reported between 1996 and 1997, respectively. And in Bangladesh, in 2010, over 600 people were killed in an anthrax outbreak due to consumption of infected meat. In 1995, large number of cutaneous anthrax was reported in Spain, Central America, and Africa. And in India, between 1991 to 2010, the National Animal Disease Report that among the 10 major diseases causing deaths in livestock, anthrax is among them. And in India in 2013, several people died of anthrax from consumption of infected goat meat. So from all this, you can see that most of the human infection, arises from either contact or consumption of animal meat or animal products. In Nigeria, information on anthrax outbreaks in Nigeria dates back from 1929. Based on the NPRI annual report of 1929 to 1965, there were a lot of reports of outbreaks of anthrax in Nigeria. And most of those outbreaks were sporadic. An outbreak was reported in 1936 involving the death of many cattle, 304 goats, and 35 sheep. These reports were mainly in the Sokoto province, which is in northwestern Nigeria, the Adama province, which is now in northeastern part of Nigeria, and then the Benue River valleys, which is in north-central Nigeria. Now, from 1952, with the introduction of the anthrax spore vaccine, which is the STAN 34F2, which is the one that has been adopted in many countries of the world today. has progressively reduced the field outbreaks of anthrax in Nigeria, because in the early 50s, 60s to 70s, there was mass vaccination of cattle, and that reduced the outbreaks of anthrax. But recently, we have seen the resurgence because the vaccination campaign has drastically reduced. So between 1970s and 80s, few cases were reported in Sokoto, Kano, Zaria, and Lagos. And mainly the Lagos ones are trade cattle. And then Nigeria also reported 425 human cases between 1988 to 1995. And this was through contact or consumption of infected animals or their products. So serological, tests also detected antibodies in livestock from Southeast and North Central Nigeria. And recently, one of the strains of Bacillus anthracis that was isolated in Nigeria was, sequenced and molecularly characterized, and it was found to belong to the unique West African lineage, which is also seen in Chad, Cameroon, and Mali. So from all this that I've highlighted, it shows that the environment, the animals, the humans, are interacting, and they also form a very key, base for the spread of this disease. So where was this bacteria before most of these outbreaks? And as has been reported, these outbreaks sometimes, most times, are sporadic. So where is this bacteria? Where does it hide? Just like Professor Fashina earlier mentioned, this bacteria is very hardy, especially when it has sporulated, because the spores can remain in the soil for over 50 years. So it means that when an animal dies of anthrax, whether it is a domestic animal or a wild animal, and sometimes when the animal is not properly, buried, these bacterial spores are there in the soil. And any activity that exposes the soil, will expose the spores. And when animals graze, especially at the early part of rainy season, they are likely to pick this infection. So are they in the soil? Are they in the wild? And then others, which could be other animals. So these are areas that that needs a lot of investigation to be able to find out where this bacteria hides. And when the conditions, favorable conditions present itself, then, infections come in. So what are the animal species affected? And we've highlighted that virtually all animals can be affected. And then the geographical location. There are areas, just like Professor Fashina mentioned, there are hotspot areas. So if we identify those hotspot areas, surveillance activities can be carried out so that, early warning, can be reported so that preventive actions are taken. Now, in Nigeria, the recent outbreak, the index case was reported on the 17th of July, 2023. It was an outbreak in a cattle farm in Suleja in Niger State. This was animals that were kept in an enclosure. And from investigation, some animals were introduced into the farm, and those animals likely from the investigation that was carried out are the source of that infection. And, it was difficult to trace where that animal came from because the animal was from the market. It was given as a gift. And then on the 25th, there was also an outbreak in Lagos, and that outbreak involved cattle, sheep, and a camel. Again, it was also a farm in the Lagos city. And on investigation also, it was discovered that there was also an introduction of, some animals into the farm. Possibly, again, could be the source of infection of that farm. There was also a report from the abattoir. But, thank God, up till now, there is no confirmed human case. So these are the areas where we had the cases in Suleja in Niger State and then in Lagos. So like I earlier mentioned, there are, to really understand this this anthrax disease, there are risk factors that, are associated with this disease. And it is very important that Sorry, this slide should come before that one. I'm sorry, slides are mixed up. So risk factors that contribute to the epidemiology of outbreaks of this disease. Like I earlier mentioned, this disease usually, for most of the outbreaks, starts from animals before it gets or spill over to humans. So it means that, the animals get this infection most likely from, the environment while they are grazing. And it has been, shown that alkaline pH soil, high organic soil content, moisture, and ambient temperature favor the germination of the Bacillus anthracis spores into the vegetative forms. So when the animals, as they are grazing, they pick these spores and then come down with the anthrax disease. Then from there, it spills over to humans. Also, natural disasters such as earthquakes in anthrax endemic areas have resulted in environmental and public health consequences due to increased potential for human exposure, not just human exposure, but also animals. And this, has been found, especially in areas where there are earthquakes and other natural disasters, because they, like we've said, these anthrax spores could be in the soil or in the ground, and when activities that bring up this underground soil up, it exposes animals to infection. And then excessive precipitation or rainfall, high rainfall, also contribute to this outbreak of this disease. Flooding also has been associated with, outbreaks of anthrax, especially in areas where flooding has occurred. Again, this flooding, exposes some of these spores that has been in the soil, and it exposes when animals graze in those flooded areas, areas that have receded due to flooding. Most times animals are exposed. And then introduction of infected animals into a herd of flock, like I mentioned, especially the index case in Nigeria. The recent outbreak in Nigeria was thought to be due to introduction of an animal. And this animal must have come from a market. And because of the porous border that we have, especially in the West African region, there is virtually free movement of animals. So once there is an outbreak in any part or any country in Africa, especially in West Africa, there's likelihood that this will spread. And that was one when there was an outbreak in Ghana, Togo, and Burkina Faso. Nigeria was placed on a red alert. So handling of infected animals or consumption of infected animal products also could So some of the recommendations to combat and reduce the risks of anthrax outbreaks, just like Professor Fashina earlier mentioned, there is need for collaboration, and One Health approach is very, very key because, like we have identified, the environment is very critical, the animals also are very critical, and then the humans. So there is need for this One Health approach for both investigation, so surveillance, and also for the outbreak management of this disease. Early and timely reporting of suspected cases of anthrax in both animals and humans is very, very critical and very key for immediate response. Passive and active surveillance, I've mentioned, is very key. And also vaccination of animals. Vaccination, like I earlier mentioned, continuous vaccination drastically reduce the outbreaks of anthrax. So because it is a preventable disease, when animals are properly vaccinated, it will go a long way in reducing the risks of outbreaks. Public education and awareness is also very key. Proper disposal of dead animals and contaminated materials. This is very, very key because, like we said, when an animal dies of anthrax and it is not properly, the carcass is not properly handled, it will serve as, a point or a source of further infection. And this can take years. And that's why this disease has, remained with us, and it's probably because of this improper disposal of dead carcasses. Then biosafety and decontamination of environments contaminated with anthrax using appropriate disinfectants is also very key. Strengthening of veterinary and public health laboratories at all levels. This is very, very key for surveillance and also early detection. Then collaborative research is also very important because this collaborative research will help to better unravel and understand the dynamics of this anthrax transmission and its also epidemiology. So in conclusion, this anthrax being a very a dangerous pathogen and a zoonotic disease with high economic and public health impact requires intersectoral collaboration to fully understand the epidemiology of outbreaks and how to combat it. Thank you very much.
Thank you, Dr. Ungulukun. Thank you for that brilliant and informative presentation. Yeah, during your presentation, few of information that I'm able to gather is you're able to give a detailed transmission cycle of the disease. You also make an elaborate historical data on the disease across the globe, especially in West Africa. And equally, you do the handful of recommendation that will assist to combat the disease. Thank you very much, Dr. Sati. Kindly be on the standby for questions from our participants. Yeah, before I proceed to our last speaker, I would like to remind our participants we can post our question and answer on the Q&A box downstairs. It's on the underneath of the Zoom platform. You can post your questions and the speakers can attend to the question. Then you can kindly assist by giving your details, your name and where you're joining us from at the chat box on the right-hand corner of the Zoom platform as well. So thank you. Yeah, I will be going to the last speaker for today, Dr. Kayode Femi. Dr. Kayode Femi is a veterinary surgeon, a passionate change leader with more than a decade, 15 years precisely of experience in leading innovative solutions in animal health and disease prevention across Nigeria. In 2020, on the governing board of the Veterinary Council of Nigeria, a government body responsible for regulating the training and practice of all veterinary surgeons in Nigeria. As the youngest member to be elected in the history of the governing board, Dr. Kayode has led the board in critical aspects of its operation to adopt cutting-edge technology in delivering on its core mandate. He is an Ashoka Fellow since 2018 and Making More Health Fellow since 2020. Proudly, Dr. Kayode Femi is the founder and CEO of Farmalart, a leading animal healthcare brand in Africa, enabling easy access to affordable animal healthcare in undeserved communities in Africa. Dr. Kayode Femi will be speaking to us on promoting biosecurity measures to prevent the outbreaks of anthrax in West Africa. Dr. Kayode.
All right, so
Yeah.
I'm not sure if you could see me properly. It's good afternoon, everyone.
Good afternoon.
I guess my lighting is a little bit poor, but happy to be here. And I want to please also give credence to what it is that you're doing. I think education is a fundamental tool in causing system change. I'm an Ashoka Fellow. And one of the key things we talk about during our meeting, it's our ability to cause system change, probably using some of our challenges. Of course, now we are concerned about the anthrax outbreaks that we have currently in Nigeria. So I'm happy to be here and well done to the GET team. Of course, I will not be comfortable to start this presentation without acknowledging Professor Florence Fashion, who has been like a trailblazer in the veterinary community, and frankly has tutored quite a handful of us. We look up to him, and then we acknowledge the great strides he's making, both locally and internationally. Of course, talking from Rome today, and to our own Dr. Sati. The MVRI has been at the forefront of disease diagnosis in anthrax for the past couple of weeks that we've had that challenges. I really don't know what we would have done if MVRI wasn't in existence. We would not have vaccines. We'll probably all be in trouble. So thank you, Dr. Sati, for the great job that you're doing. And MVRI is collectively ensuring that we go past this issue in no time. To my presentation, my own topic is very simple, but simple, thoughtful, but should form one of the bases in which we all should premix the prevention of anthrax disease in Nigeria. We heard a few weeks ago, we heard it was in Ghana. And while we were holding a public lecture, we all knew because of our porous border that it will soon be in Nigeria. A few days after we confirmed, as you heard, in Niger, and then Lagos followed suit. I still have a feeling that we still have the anthrax outbreaks across the country, but not yet diagnosed. Because once biosecurity is not properly in place, the spread of disease is easy. In fact, once movements are not contained or animals are not properly traced, you really can't tell to what extent a disease can go in its devastating effect. So in as much as biosecurity is one of the most commonly used words, I still think it's about the fundamental activity or fundamental phrase that needs to be in place for any national disease outbreak to be curbed. Because the more you restrict the movements of animals here and there, the better you can, of course, handle some of the disease spread that we currently have. So I'm going to take it simply and quickly because of our time. So what is biosecurity? It's just simply reducing the risks on your business, or at this point in time on a farm or on a nation, by limiting the likelihood of introducing and spreading this disease across the various regions in concern. So what are the benefits of a biosecurity measure? Well, if you reduce disease incidents, you could enhance productivity on your farm, or our farmers in Nigeria, as the case may be in the case of anthrax. Loss of livestock. I can imagine a sudden death of an adult cattle. An adult cattle in Lagos is going for an average of 500 to 600,000. So just imagine that you wake up and then 10 of your cattle are dead, bleeding from the nose or various orifices. 10 multiplied by, let's say, an average of 500,000, that's 5 million loss in one day. There's very little business skill you need to know that once there are losses on your farm, you're going down the drain. Your productivity as a farm is being reduced drastically. Then we also know that the risks on your farm with a proper biosecurity biosecurity measures are reduced. When you have a proper biosecurity plan, there's early detection and management of some of these diseases. And then, of course, during outbreak, with a proper biosecurity plan, you can reduce your cost of managing most of these diseases. So what do you need? I'm going to offer a few basic steps in ensuring a proper biosecurity, first on farms, because I assume that we have a couple of farmers on this call. Then I will talk on a national scale towards the last two slides that I have. So everything brought into your farm, you need to check. So I usually advocate, especially around Nigeria, people use their farm as storage sites. I got a clue from one of my, the person I follow, Dr. Ayola Odunton. He said he went to Brazil, and the moment they noticed he's coming from Nigeria, they didn't even allow him enter the gate, not to talk of entering the farm. Right. So for us in Nigeria, the situation is slightly very different. We have people confidently take visitors to their farm just to showcase that they have abundance of cattle, or to showcase their wealth. In as much as I don't question that activity in its entirety, but a biosecurity, proper biosecurity measure will limit these activities. So you have to also ensure that any introduction of a new livestock into your farm, you need to isolate them. Where did you get them? Are there health certificates for them? We really don't promote the use of health certificates in our country, but it's important to note that if you're bringing in a livestock, and there are several influx of livestock, we have bordering states. We have a distribution center in Taraba, in Gembu to be precise. And Gembu, you could take a bike from Gembu to Cameroon. It's that easy. But the influx of cattle from Cameroon, how strong are those borders? Are they coming with health certificates? You see, because if you're introducing new livestock from another source into your farm, you need to be sure of what's the health status. Are they incubating any disease that could virtually close down your farm? Are there things you need to do? So if you're bringing in livestock, you need to be sure of where they are coming from. They need to have a certificate. You need to have veterinarians around that check some of those livestock. You need to isolate them for probably a period, 7 to 10 days, to allow whether there's going to be signs of disease. You need to also ensure that you're getting most of your input for the farm from reliable sources, people who can guarantee that these things are not infected. If you're taking your livestock away from your farm, part of the measure is that you also need to certify that the livestock you're taking out of your farm is fit to travel, is fit for the market. And that's why I keep advocating having a veterinarian on your farm, because some of these diseases, you really can't tell exactly what it looks like when it's not obvious to the farmer. The farmer only concerned probably when their livestock are off feed, or when they are not eating properly, they are losing weight, or probably in the most intense case, death. But a veterinarians are able to pick up signs, early warning disease signs, and able to instruct you appropriately. So if livestock is going out of your farm, it needs to also be verified. You can't supply an animal that is sick, or an animal that it's not really very healthy for the market. On biosecurity measures also for farms, you need to be sure that your visitors are properly dressed. You need to encourage protective clothing and within the use of your farm, within your farm, ensure that your farms, your staffs are properly clothed. We're not talking about poultry farms now. Even now, we'll have been talking about food dips. But of course, in cattle farms, food dips are also very necessary in case you are getting a vet into your farm to come and vaccinate your farm. Part of also biosecurity is an established active livestock monitoring and record keeping. This might not seem obvious because once you don't have the data in your farm, you don't have the records in your farm, it's difficult to know what you've done and what you have not done. How many of your livestock are vaccinated? How many of them are not vaccinated? Which kind of vaccines you do? So part of the biosecurity measures we also encourage within farms is proper recordings. You vaccinate and drench stocks on entry to prevent the spread of disease and spread of any sick or any suspected case. I want to quickly move to the last two slides for our time. Health advisory from livestock owners. Vaccination is the most effective preventive measures against anthrax in livestock. As I said initially, consult with a veterinarian to develop a vaccination schedule suitable for your specific livestock. Use personal protective equipment, gloves, face masks, goggles when handling sick animals. Do not slaughter, and this is very important, do not slaughter a sick animal. Slaughtering sick animals can expose the anthrax spots, because right now, we don't know whether it's anthrax or another disease. You're safer not quickly slaughtering a livestock that is sick, because the spores, if the person slaughtering or the person handling a diseased animal can be at most at risk if just in case that livestock is suspected to be having anthrax. Regularly monitor your livestock for any signs of disease, and then do not process or move dead or sick animals quickly. Report to your veterinary doctor or veterinary authorities at the Ministry of Agriculture in your state. Maintain good hygiene. Biosecurity is a lot on good hygiene. Proper cleaning, ensure your farms are good, proper biosecurity measures, controlling access to your farm, restricting the movement of animals, disinfecting vehicles and equipment, and leaving your premises safe and clean. I think I want to stop there. Thank you very much.
Yeah, thank you, Dr. Femi Kayode. Thank you for that brilliant presentations as well. Yeah, this is quite practical. You gave a practical overview of on how to operate farm in a biosecured atmosphere, at the same time getting the maximum benefit from the same farm. Thank you. And kindly be on the standby. We'll go straight now to question and answer section. Most of the questions I can see here have been answered by the presenters. Yeah, the first question was addressed to, okay, this question is being addressed to Dr. Sati. Are there bodies or organizations in East Africa that you are collaborating with in the epidemiological investigation of these threats? And then additionally, what holistic approach are you handling towards anthrax, especially in community settings? This question is
Okay.
for Dr. Sati.
Yes, okay, thank you. So quickly, for now, we don't have any bodies, organizations from East Africa that we are collaborating on anthrax yet, but we are happy to collaborate with any bodies or organizations. We'll be glad to, have that collaboration because I know they have a lot of experience with anthrax. So we'll be glad to partner and to collaborate on any aspect of anthrax. On the second question, what holistic approach are you handling towards anthrax, especially at the community levels? Now, one of the, before, the anthrax outbreak in Nigeria, Nigeria had developed a national strategic plan on anthrax, even before the outbreak, because we knew from, the outbreaks in some West African countries, we knew that likely we are going to have outbreak in Nigeria. And Nigeria had prepared earlier for that. And also as part of the response, we also have a One Health team and a One Health, technical working group for anthrax. And there is an EOC center, and part of the activities is, engagement with the communities in terms of advocacy, in terms of awareness, and that is ongoing. In fact, there are radio programs, at some community level, especially for those areas where the outbreak has been confirmed, up to, at the level of the communities using the local dialects. So there's a risk and communication team that is responsible for that, and they're engaging communities to, get them aware of this particular disease. So thank you. I think the other question is also the challenge of vaccination in Nigeria. And I'll also tie that to whether we have locally produced vaccines in Nigeria. Yes, Nigeria, through NVRI form currently, and has been producing anthrax vaccine. And like I mentioned, even though the people or farmers don't normally vaccinate against anthrax, but there are some farmers that consistently vaccinate against anthrax. And like I earlier said, NVRI produce enough vaccines that can go around the country and even beyond the country. And recently with the outbreaks, a lot of requests have been placed on NVRI to produce enough vaccines, and I can tell you that there's enough vaccines in stock. And the federal government has requested for vaccines, and some state governments have also placed requests for vaccines. In fact, some of the state governments are already, doing some kind of mass vaccination. And if you recall, the Federal Ministry of Agriculture and Food Security has also, bought a lot of vaccines, and they have deployed such vaccines, some of the vaccines to Niger State, to Lagos State, and other states. So Nigeria is, most states are currently vaccinating against anthrax. And so anthrax vaccine is produced in Nigeria, and NVRI VOM does that. And also, the challenge of vaccination is that I think there is need for advocacy. When the outbreak in Niger State happened, I was part of the team that went to Niger State for the investigation. And when we visited the emir of Suleja, one thing he mentioned was that that during the time when he was young, he remembered that, vaccination was compulsory. If you have animals, especially cattle, you must vaccinate. And there were people that go around to check whether farmers have, have done their vaccination. And he advised that should be brought back. And, like I mentioned earlier, because there was, routine vaccination and yearly vaccination, that reduced the outbreaks of anthrax, and it has been proven all over the world that where there is, mass vaccination, especially for some years, it has drastically reduced the incidence or the outbreaks of anthrax. So the challenge is that is there, but I think there is need for advocacy, especially state governments to take up this, and then also farmers should take it as a responsibility because it is their business to ensure that they vaccinate their animals against anthrax and other diseases that vaccines are available. So I think it is to continue to advocate for people to vaccinate their animals, and also for governments, both at the federal and the subnational levels, to also support farmers. Yeah, since we are lucky to have the vaccines in country. So it's to continue to advocate for governments and also the farmers to ensure that the vaccination is carried out routinely. Thank you.
Thank you, Dr. Sati. Thank you. Yeah. The next question that is not been attended to is, with those anthrax outbreaks undertaken in West Africa, what are your learnings or insights can you share with us? I want Dr. Hold on. I mean, you've attended 2 questions here. Let's hear from Professor Folorunso. Prof.
Thank you very much for the question. I thought because they thought of West Africa that he will attend to it, but it's okay, I can attempt it. One, in terms of outbreak management and disease management, one, we need to understand first that disease has no border. And especially with the current situation we are in, an experiment was conducted and a man was able to travel across 3 continents in less than 24 hours, taking time to interact with people in each of these continents. So it means that looking at it that way, a disease challenge with our neighbor is a disease challenge with us, actually. And that is the reason why immediately there was a challenge in Ghana. Nigeria began to put in place and to implement awareness, control, vaccination, and heightened surveillance. This is important. So one of the things we can do with one of the learning we can do is, one, we need to be at the preparatory mode. We should be able to trigger the necessary actions immediately we begin to see such challenges. Another thing is that we should be willing to share information across borders. For example, if this situation has been happening in Ghana and nobody had mentioned it, or the Ghanaian government had kept it under lock and key and said nobody should say it, you will definitely have many cases of anthrax in Ogun, in Lagos, and in some of the southwest part of the country. And this animal may be moved around the country, and then you have a massive fire of outbreak of anthrax in your hand. We've had the same situation with African swine fever before. It came through Togo, Benin, entered Nigeria, and it spread like wildfire in the country in 96, 97. We've had the same situation with avian influenza. It moved across many West African countries. So these diseases, you don't need to wait until the challenge is right there in your hand before you begin to handle it. And then we need to have proper documentation. For example, we talk of documentation with regards to how animals move across the border. Dr. Femi emphasized that. That's well, we may think, oh, cattle are resilient, they will not die, let them just move freely. How are they moving freely? What are they carrying with them? What risks do they carry? Are there areas where we can do monitor, maybe just do random surveillance for these diseases and get to learn from whatever we do? And this information, for example, Dr. Sati presented information from MVRI form. on the cases of anthrax we've had in the country over the year. I believe those are not comprehensive information. If we get to the field, I've been to Adamawa, Taraba, Gembu, Gashaka, all those areas. If you see the way these animals move and they cross the boundary, you will definitely know that we have more challenge in our hand than we actually think we have. This will be my thoughts. Thank you.
Thank you, Prof.
Thank you. Thank you, Prof. Just to add a few, Prof have said it all. You know, disease now does not respect border. And especially in West Africa, where, you know, there's this free movement of animals across borders, including human beings. So that is a challenge. But then it is for these countries to come together, you know, to see it as a big opportunity by collaborating. And I think one of the key things to do is to continue to advocate, you know, for governments to take responsibilities in, you know, educating their people, and also to, you know, to strengthen the animal health system across, you know, the West African sub-region. Because if the animal health system is strengthened, you know, and then this vaccination is part of the animal health, system. When animals are moved across borders, you know, in those days, I was told that, you know, when you are moving animals across, you know, the West African region, there is need to show that your animals are vaccinated, especially against some of these transboundary, you know, animal diseases. And I think the West African countries, especially ECOWAS, will need to, you know, sit and discuss and agree on some of these measures. It will go a long way in controlling some of these transboundary diseases across the West African sub-region. Thank you.
Thank you, Dr. Sati, for that. Yeah, I have Dr. Haminu Mohammed raising his hand. Dr. Mohammed, yeah, you can ask your question, please. Dr. Aminu, I think Dr. Aminu. All right, I think Dr. Aminu, if you can hear me, once you can hear me, you can unmute yourself to ask the question. Let me go to the next question, to another question that has not been answered. I think Professor Femi has attended most of the questions. Yeah, I think he has attended most of the questions. Yeah, I think most of the questions have been answered by Professor Femi and Professor Folorunsho. But I don't know if Dr. Kayode wants to add to any question here. Dr. Kayode.
Okay, so it's just to, well, when your professor has spoken, just to add a little light to what we are dealing with in this country. So I heard from the MVRI director in the last meeting we were in, that for the last 20 years, we've not recorded a single case of anthrax. So it means that some of us went to school, we finished our entire veterinary course, and we only heard of anthrax in the books and not in practice. But right now, we are beginning to see classical signs come up. And the challenge with what's happening now is once there's we don't have a strong grasp on the entire movement of cattle, then this disease will equally stay like other diseases that have stayed for a long time. So the best thing that I think this meeting is supposed to help us advocate is that everything starts with you. And it starts from you. So if you have farms, ensure these measures. You cannot, and we also need to tax. Thankfully, we still have a few people in government around us. We're expected to meet with the minister in a couple of minutes. And one of the key things we want to also say is that policies should be designed, but more importantly, policies should be implemented. The life anthrax is zoonotic. So the life of humans are at risk, not just the life of animals. And although life is life, but these things need to be followed through and through so that we can safeguard the future of the livestock industry and also safeguard the future of our public health system. We still have a long way to go in Nigeria, but with the likes of the people we have in this call, one step at a time, I think we'll all get there. And one of the critical learnings, and lastly, actually, that I'm beginning to learn from this anthrax disease outbreak is that it can facilitate collaboration. So I never knew about GET, but something is bringing us together. Somebody mentioned to me that the same way you bury a dead person is the same way you plant a seed. So, but different outcome. Challenges could bury us and we will not find a way out, or it could grow us as a community and grow our togetherness, grow our collective resolve to solve a single problem. This is bringing Professor Fashino, Dr. Sati, us get together, and also bringing some human counterparts together. Once we continue in this terrain, figure out how to solve these national issues together, two things happen. We grow as a community. More importantly, we also build a platform or a template that could help us resolve other issues that could be a threat to both humans and animals in the future. I think that's about what I need to say regarding this.
Thank you, Dr. Femi. Thank you for that. I think I have another question from Dr. Kolawole Salami. Yeah. What is the status of animal disease surveillance? Is it as robust as surveillance for human infectious diseases? Are there legislation in place to enforce this, such as yellow card for humans? How can we improve on it? Is there a party, NGO, or interested in funding or improving this? I want Dr. Sati goes first.
Okay, thank you once again. Well, yes, there is a structure for disease surveillance. In the country, we have what we call NADIS, which is resident in the Federal Ministry of Agriculture. NADIS is National Disease Information System. And currently, just I think about 3 or 4 weeks ago, some resource persons or trainers went around the 36 states of the country, training, disease surveillance officers at the state and the local government levels. Because very soon that NADIS platform will be activated. What they said was after the training, which they just completed a week ago, and I'm very sure that it's going to be activated and it will be implemented. It is robust, and I'm sure that, well, I remember also when the Department of Veterinary and Pest Control Services briefed the ministers, the newly appointed ministers of Agriculture and Food Security. I was privileged to be in that part of the delegation, and it was re-emphasized. And the minister also gave his word that he wants that surveillance system to be part of a key, or to be one of the key activities of the ministry. So I'm very sure that the surveillance system going forward from now will be strengthened. We are not yet there, like I said, but there is need actually for strengthening the surveillance systems for animal health sector. Now, with the One Health approach now, you find out that, it's not just, we cannot just afford not to, activate and strengthen the surveillance system, because as Professor Fashina earlier mentioned, diseases now does not respect borders. It does not even respect whether it's human or animals. So we must, all of us, whether it's the animal health sector or the human health sector or the environment sector, have to come together if we want to have, a healthy nation and a healthy society. These three sectors must collaborate. And surveillance is one of the key, activity that has to be strengthened and implemented. So like I said, the animal health sector, being pushed by the Federal Ministry of Agriculture, is working to implement the disease surveillance system in the animal health sector. Thank you.
Thank you, Dr. Sati. I have seen that Professor Folonsho has equally put few words about that same question. But I don't know if Prof will want to have a parting shot with that.
Yeah. Thank you very much for giving me the platform again. It's just a matter of emphasis and addition to what Dr. Ngulukun has said. You know that, for example, for human diseases, most of them are dealt with like programs. So it's easy to mobilize specific money for maybe malaria program, polio program, cholera program, and all those things. So it's easy to get a lot more fund coming in for the public health activity compared to the animal health activity. Maybe that's one lesson that we can learn from the public health, and see how we can begin to structure animal health challenges into programs so that we don't lump everything together. For example, if you look at most of the surveillance done for animal diseases or so, everything is lumped together under one single box. And so it depends on who can struggle to get more of the fund. That is what determines what happens. So you can remember when we have the challenge of avian influenza, you found out it was easy to address avian influenza because we take it similar to a program approach. Indeed, I remember the World Bank alone gave Nigeria $50 million in response, in terms of strengthening response to avian influenza as a country. But for most of the other diseases, we just lump them together as one lump sum, and it makes funding a bit of a challenge. So we need to begin to learn from that. I also emphasize the issue of coordination. You see, most of the time, the coordination structure is really not in place. Thank God for an organization or for a body now like NADIS coming on board that will strengthen a surveillance. So the coordination arrangement has to be in such a way that you can have a lot of interactive engagement between the private, the public. For example, Dr. Femi is here now. He may be willing to give you hundreds of millions if you talk nicely to him, but you need to get him to do that by massaging his ego well. I'm sure he will attend. He will confirm what I've said. But apart from that, you see, if you have this engagement wherein both the public and the private talk from time to time, when you have challenges in your hand, you put it on the table, you discuss it together, including the pastoralists. See, one of the mistakes we have is that we do believe that those pastoralists are poor. Indeed, that was my assumption until about 2009. We went to Gembu Gashaka to go and attend to a situation of FMD among the pastoralists, and then we were pitying the Ardo. The Ardo is the head of Fulani community, and we were saying, oh, this disease will cost us about 50,000 to get all the things we want. You can imagine what 50,000 is in 2009. After we finished talking, my salary was a little over 50,000 around that time. This man went, he just told one of his boys to go in and brought 200,000 and put on the table and said we should start immediately. I was wondering, how can this man get 200,000? So where you think the resources are, the resources may be there also. So in terms of coordination, bring everybody on board, discuss this issue robustly together, and see how you get everybody working. And if you are able to do this at the national level, you see that engaging the international partner and another partner will also be easy to be done. So I believe that it's possible. And in terms of vaccination certificate, definitely there are vaccination certificates. It may not be at its best in terms of implementation, but they are there. Thank you.
Thank you, Prof. Thank you for that detailed information. Yeah, while we will be rounding question and answer session, we'll be rounding up. But while there, I saw Dr. Kayode, he was laughing. Do you want to add something? I saw you.
Just to quickly
You can use words now.
Just to quickly do a disclaimer. But again, I think the structures for these are there in Nigeria. There's a structure for effective disease reporting. Well, Professor Fashina has suggested if we'll have programs, develop these things into projects or programs, it's easier. And there are quite a handful of funds for that, as we all know. But I think our presentation in the animal health sector hasn't been that coordinated. But some of us are beginning to pick that up and working with some of these various international funders to see how we can build in a very nice structure to aid in surveillance, and more importantly, so that people who have the authority to make decisions can have access to the exact data they need for quick and effective decisions. Thank you.
All right, thank you very much. Thank you, our speakers. Thank you very much for that. I think you have learned quite a lot today on anthrax. All right, so as the webinar gradually moves to closing, I want to express our gratitude to all our speakers today. They've done quite wonderful with their presentation. Dr. Ungulu Kumsati, thank you. Professor Fashino, we're really grateful. And Dr. Kayode Femi, very, very grateful for taking out of your time to share your knowledge and experience with us. We sincerely appreciate that. And kindly oblige us if we need your attention in future. Thank you for that. All right. To all our participants well across the globe, from Africa, America, Asia, and Europe, you are all represented today. I say a very big thank you for attending today's webinar and also keeping faith with us every month on this educative and informative platform. We appreciate your time, and we do always look forward to your participation every month. All right, by my time, I think we've spent well over about 2 hours now. We will be rounding off today's webinar very soon. But before we go, I want to inform you more about GET. I indulge all our participants and attendees to visit our website and all our social media handles, the Twitter, the LinkedIn, the Facebook. We are there for your catch-ups. You can get more of our activities and events as it goes. We have our registration for annual biosecurity conference. The registration is still ongoing. We are still open for abstracts. You can still submit your abstracts to participate in this year's conference. You can visit our website for more information about the conference, on how to do the registration, how to participate in it, the fees and the activities and all. So also we have our biosecurity journal. It's one of its kind globally. We just launched it, and it's open for fellow researchers and colleagues. This is a great opportunity for you to publish your research works around biosecurity and biosafety and related field. And again, we have our newsletter, our quarterly release newsletter. You can also contribute by adding your write-ups and your information you want people to hear across the world. It has a global appeal, so you can get to hear across the globe on our quarterly release newsletter. So I would like to add to our teaming participants, there is a certificate at the end of the program. We will share the certificate, and even today's presentation, we will share the slides with you on your email. So that's yeah. On that note, I think we've gone far for today. We've done a good job for today. I want to draw the curtains on today's webinar. It's a perfect way to end today's webinar. So if you have enjoyed today's webinar, kindly join us again for next month for another exciting and informative webinar series. My name is Dr. Babatunde Taiwo. I say have a wonderful, enjoy the rest of your day, and goodbye from here.